بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, this is a good morning for everybody. This is the first session in the third day. We'll start with Dr. Khalid Al-Mani'. He's a senior consultant in the pediatric radiology in the King Faisal Specialist Hospital in Riyadh, and we'll start by first topic, easy approach to the bone dysplasia. Please, Dr. Khalid.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I hope you will find my session a little bit comfortable. I'm not going to speak in a language away from usual radiologist. Bone dysplasia is a nightmare for any radiologist, and they try to escape by reading them. The pediatric radiologist is not a special radiologist that he can approach it, but we find some tricks, and I'm going to share my tricks with you. What we need in order to read bone dysplasia. We need radiological knowledge, we need clinical information. Usually they don't give us good clinical information, and we read the references, and today with the internet the references became easy. Normal, variant, and normal, we learn it from the time of residency. After that, we need to know things like terminology, that we speak the same language. We need to know something very important. There are bone dysplasia with a specific picture, and those are the ones which we can shine. We can really become excellent radiologists by telling them this is typical of this thing. And there are bone dysplasia which is not specific, and we can approach it in a special way. We have to speak the same language. We have to have the same terminology. What we mean by that? If you see that all the sutures are fused, what you are going to call it? Craniosynostosis. Syn means fusion. So this is a fusion between the bones of the skull. The fusion could take any shape. For example, this called clover leaf appearance, clover heel berseem. So this sutures has been fused in a way that it is giving us a clover leaf appearance. If only one suture, not all the sutures are fused, you will find the skull is elongated in the direction of that fused suture. For example, coronary suture, if it is fused, it will give you a brachycephaly. Brachycephaly means the width of the skull is increased. What we call the scapula, if it is raised, rotated, and fixed. Springle shoulder, and could be a bone which is joining that scapula to the cervical vertebrae. Usually the limb, we call it melia. So if the limb, it is affected by the part which is near to the trunk, we call it rhizo. If it is the middle part, it is meso. If it is the distal part of the limb, we call it acro. So if we lose the rhizo, meso, and the acro is attached to the limb, we call it phocomelia. If we lose the radial part of the limb, we lose half of the limb. So it is hemimelia. And we call it by the bone which is we losing. So if we are losing the radial, we call it radial hemimelia. If we lose the ulna, we call it ulnar hemimelia. If we don't lose the thumb, only the radius, this is incomplete hemimelia. And if we lose the fingers in the middle of the hands or foot, we call it lobster hand or split hand or foot. This is an example of phocomelia. We almost has lost all the bones in the rhizo, meso, and the hands is attached to the limb. If we are affected by the meso and the acro part of the limb, we can call it acromesomelic dysplasia. This doesn't mean that we have reached a diagnosis, but at least we are speaking the same language of others, and we can look for these things in the internet. We can have the differential for that one. If we have the radius and ulna, which is abnormal, short, broad, so this is mesomelia. And you can tell the physician, I have a mesomelic kind of dysplasia, and you can link it to the clinical application. Fusion between the radius and ulna is radioulnar synostosis. Here we have lost the radius and we have lost the thumb, so this is radial hemimelia. Here the thumb is still there, so this is incomplete hemimelia of the radius, and you can see it in TAR syndrome. TAR is a thrombocytopenia absent radius syndrome. This is the list of things which you may see it with what you call it radial ray syndrome. Radial ray syndrome is just a term when you have radial hemimelia, Holt, Oram, Fanconi, TAR syndrome, sickle, the trisomies, and if it is due to drug. Clinodactyly. Clinodactyly means the little finger is curved to the lateral aspect. It is just the description of that finger, and could be the other fingers are affected, and usually it is due to the hypoplasia of the middle phalanx. This is not diagnosis. This is one kind of things which can be associated with bone dysplasia, and we have to know this terminology. We can have a fusion between the carpal bones. Lunate, triquetral, trapezium, trapezoid, capitate, hamate, as you can see it in this one, are fused. Polydactyly is a common finding. If we find the polydactyly on the side of the thumb, this is a preaxial. If it is on the side of the little finger, this is postaxial. Preaxial, you can find it as a solitary finding, or you can find it with a syndrome. But postaxial, which is on the side of the little finger, usually syndromatic. Syndactyly means fusion. We know syn is a fusion by now. Dactyly is finger. Syndactyly could be soft tissue, could be bones, and could be both. And this is a bone syndactyly, soft tissue syndactyly, plus there is something else. If you look down, you see symphalangism. Symphalangism is the fusion between the phalanges. When we lose the fingers in the middle, this is split hand or claw hand. Claw here. If we lose the normal modulation, and you can see the distal femurs are a little bit ballooned, this is called Erlenmeyer flask deformity, and it is also one finding which you can find it with the bone dysplasia or metabolic bone disease. When we have defect in the proximal part of the femur, the term is proximal focal femoral deficiency, and it is 4 types. We know that stimulation for the formation of the acetabulum is the presence of the femoral head. If there is no femoral head, there is no acetabulum. So you find A and B, there is acetabulum because femoral head is there. C and D, there is no acetabulum because there is no femoral head to stimulate the formation of the acetabulum. So this is, you can see there is acetabulum, there is femoral head, but there is defect in the neck of the femur. And this is a type A proximal focal femoral deficiency, PFFD. These are several examples. The first one is type A, and the one which is a type D means that there is no femoral head has stimulated the acetabulum, and type C is the tapering of the proximal femur, which is like a pencil-like tapering of the proximal femur, and usually it is very short. When we lose one of the bones, tibia or fibula, we call the hemimelia by the name of the bones we are losing. Even if it is partial, for example, this is a partial tibial hemimelia. And here we have lost the fibula, so it is fibular hemimelia. And almost always with the fibular hemimelia, you will find the tibia is short and broad. Bowing of the tibia could be an isolated thing. If it is AL, anterolateral, it is almost always pathological. If it is PM, which is posterior medial, it is usually benign, and it is usually due to the position of the baby in utero. This is PM, posterior medial, and this is a benign. This is AL, anterolateral, and this is pathological. And if we look carefully, we can see that there is a pseudoarthrosis, and the pseudoarthrosis of the tibia could be the only finding for neurofibromatosis. This is equinovarus. We are coming to cleft feet. What means equinovarus? Equino is horse, varus medial deviation. So why they call it that? Because the horse doesn't walk on the ankle joint, and this child is walking on the toes, and it is going medial, and this is the commonest talpes equinovarus. And this is another example with exaggerated arch, and it is equinovarus. And this is the other rare type of the talpes, which is calcaneo valgus. So the child is walking on his calcaneus, and it is a valgus deformity. And this is a vertical talus. What we are doing now, we're just refreshing our memory with terminology. What we are doing, if we find a skeletal survey, which we should be sure that we don't accept what they call it babygram or limited skeletal survey. We need a complete skeletal survey. The skull and the spine should be taken in two views, AP and lateral. The rest of the body should be taken in one view, which is AP view. When we take that, we take it the first time we see the baby, if it is in the neonatal period or childhood, so we take that skeletal survey, and we try to follow up that child every 3 to 5 years in order to see the changes. It is very difficult when you face an adult with bone dysplasia and you want to make a diagnosis. Most of the bones has changed with the growth. Bone dysplasia with a specific pathognomonic abnormality. Those things you have no excuse. It is only 1-2 finding in each one, and it will give you the diagnosis. We should know those specific things. For example, if we see that there is craniosynostosis of asymmetrical way associated with syndactyly, symphalangism, which is giving us what we call it mutton glove appearance, the glove of the baby which has no fingers. So this picture with this picture of craniosynostosis, this is diagnostic of upper syndrome. If we see fusion between the cervical vertebrae associated with springle shoulder, and if you look to the CT scan there is what we call it omovertebral bone, which is joining the scapula to the cervical vertebrae. This is diagnostic of Klippel-Feil syndrome. If we see that the bones are very dense, we are losing the medullary cavity of those bones in all the bones, skull, chest, and the limbs. This cannot be but one thing, osteopetrosis. Also in the hands, you can see bone and bone appearance. And the osteopetrosis is different types, either recessive, dominant, or the third type, which is a unique type called carbonic anhydrase 2 deficiency. How we can differentiate carbonic anhydrase from the others? We can differentiate that the bone density is not the whole bone, especially the longitudinal bones. It is the end of the bones which is having this sclerotic and associated with calcification in the brain. So the other name for it is also marble brain disease or carbonic anhydrase 2 deficiency, and we can differentiate that. It is also associated with renal tubular acidosis. This is another specific. If we see this lateral with the mandible has no angle. If you look to the mandible, it is a straight line. This is enough to I tell them the diagnosis. But let me add something for it. You will have hypoplasia of the terminal phalanges. You will have hypoplasia of the clavicles, and the bones is a little bit dense. And this is pycnodysostosis. This is the only thing you will find it in pyknodysostosis. You will not find it in another bone dysplasia. If we see that the bones are abnormal, short, multiple fractures, and it is not perfect bones. So from the definition, it is not a perfect bones, it's a broken bones. There is wormium bones, what we call it, in the skull, which is the sutures around the major suture, which you know, and there's bowing of the bones, and this is osteogenesis imperfecta, and you can see even the child was growing, there is bowing, there is poor density of those bones, and there is a multiple stress lines. The vertebrae will be collapsed, and you will have vertebra plana. Plana means flat, and this is osteogenesis imperfecta. This is another unique, also specific things that has a midline defect. If we look to the anterior fontanelle, it's open, it will keep open until the adulthood. If you look to the symphysis pubis, it is open, it will be kept open for life, and there is absent clavicle. And this is a specific for callidocranial dysostosis. If you see that there is absence of paranasal sinuses, the bones are having what we call the ground glass appearance. There is expansile ground glass appearance in the bones here and there. It can affect the flat bones, can affect the tubular bones, and can affect one side of the body only, and this is fibrous dysplasia. And if it is only one side associated with endocrine disease, we think about McCoy-Albright syndrome. Achondroplasia is a group of disease, but they are sharing the same character. Also, it has very specific picture. Those are 4 groups: thanatophoric dysplasia, achondroplasia, achondrogenesis, hypochondroplasia. Thanatophoric dysplasia. The specific thing about this thing that you can look to the vertebrae. The vertebrae has a specific shape, H-type vertebrae. And if you look to the longitubular bones, they are no longer long. All the achondroplasia are short. All the babies with achondroplasia are short. If you look to the longitubular bones, it looks like the receiver of the old French telephone. And this is thanatophoric dysplasia. This is achondrogenesis. This is the worst type of the achondroplasia group. And if you look to the skull, you cannot see any calvarium, as if it is only soft tissue. If you look to the chest, it has a barrel-shaped chest. If you see fractures in the ribs, this is type 1 achondrogenesis. If there is no fracture, this is type 2. If you look to the longitudinal bones, it is like a popcorn, and this is a typical of achondrogenesis. Achondrogenesis can be A with the fractures or B without fractures. Achondroplasia, this has also a very specific picture. Short base of the skull. If you look to the spine, you see that the vertebrae, usually in the normal vertebrae, you have the interpedicular distance is getting wider between L1 to L5. Here it is the reverse. L1 is wider than L5. So this is specific. If we look to the lateral of the spine, we see narrowing of the spinal canal, and there is curvature, scalloping of the posterior aspect of the vertebrae. In the pelvis, horizontal roof, small sacral notch, and if you look to the longitudinal bones, the end of the longitudinal bones has like ice cream cone. So we call it coning of the epiphysis, as if the epiphysis is sitting in a cone of ice cream. In the short tubular bones, and this is by age of 2. Let's see when the child is growing. This is by the age of 9. Almost the same picture, and you are going to see the same thing, coning of the epiphysis and the narrowing of the interpedicular distance. This is by the age of 18. The child has grown, but these changes are specific, and you are going to find it there. What about hypochondroplasia? Hypochondroplasia is the same picture of chondroplasia which I just described in a lower level of severity. For example, the skull doesn't have the very short skull like we have seen in chondroplasia. There is narrowing of the interpedicular distance when you go from L1 to L5, but it's not as severe as that. And also the lateral will have narrow spinal canal. Horizontal roof is still there. And also you can have a little bit of changes in the metaphysis that having the coning of the epiphysis. This is also a very specific disease, and you can shine up by having the diagnosis. Just look to the chest. It is a little bit narrow chest. If you look to the hands, they can have post-axial polydactyly. And the most specific picture in this one, look to the tibia. There is a V-like lucency in the tibia. You don't see it in any other bone dysplasia. Another example, narrow chest, polydactyly, V-shaped lucency in the proximal tibia. When they grow up, this V-shape in the tibia will become like a small exostosis. And the diagnosis is Ellis-Van Creveld disease. You can shine up just by X-ray of the tibia, and you can have the diagnosis. No other dysplasia have the same thing. If you have narrow ribs and polydactyly, so it is a short rib polydactyly syndrome. If there is no changes in the tibia, similar to what we have seen in Ellis-Van Creveld disease. If you have calcification in the trachea, main bronchi, plus there is hypoplasia of the distal phalanges, this cannot be anything but acute syndrome. Calcification in the cartilage doesn't happen in children. If it happens, this is pathological, and if it is associated with hypoplasia of distal phalanges, this is acute syndrome until proved otherwise. If we are missing the lower lumbar vertebrae and we're missing the sacrum, what we call it? We call it sacral agenesis or caudal regression syndrome, and this is also very specific. If we have a spine like this, hemivertebra, butterfly vertebra, fused vertebra, usually I don't describe every vertebra. This will take a long report. I say dysraphism, means the raphism, the fusion between the ossification center of the vertebra are missing, and that's what we have, dysraphism of these vertebrae. If we look to the ribs here, the ribs are very abnormal, and there's a fusion between these ribs. So if I will want to give it a name, I will give it spondylocostal dysplasia, and if there is another example, the same thing, dysraphism and ribs are abnormal. And if you look, spondylocostal dysystosis or dysplasia, and it is just description of what we have seen, and it is also specific. This is another specific bone dysplasia. If we do it before the fusion of the iliac crest, just look to the iliac crest. The iliac crest has a lace-like appearance. You don't see it in any other bone dysplasia. If this is associated with the end plate, which has multiple humps, so this is diagnostic of DMC. What is DMC? It is Digev Melchior-Clausen dysplasia. If you don't want to remember this difficult name, pseudomorchio is the other name for it, or DMC is known for the bone dysplasia. And this is very specific, but after the age of 16 years, you are going to miss the diagnosis because the iliac crest will change in shape and will start to fuse with the iliac bone. If we have dislocation of multiple joints, hip joints, knee joints, ankle joints, multiple joints are dislocated, and you have very thin muscles. Most probably, you are dealing with what? Arthrogryposis. If you have the epiphyses, which is stippled, we know that the epiphyses are not present at birth, not all the epiphyses. But if you find that in the place of non-ossified epiphyses, that there is stippled calcification, this is very specific, and you can find it in chondrodysplasia punctata. punctated epiphysis. This is very specific. This is also very specific disease. We know that the patella is ossified by the age of 5 years. Just easy to remember, 5 in Arabic looks like the patella, so the patella is fused or start to ossify by 5 years. If you look to this patella in this unit, it has what we call it like a sword. So it is like a scimitar calcification of the patella before the age of 5 years. This is very specific for this disease. It is associated with cystic changes in the paraventricular of the brain and associated with cystic changes in the kidneys, and this is diagnostic of Zellweger syndrome. If we have absent patella in the adulthood, we know about 5 years should we have a patella. But if we don't have patella, and we have what looks, if you look to the iliac bone, there is like a horn. There is exostosis, which looks like a horn coming out from the iliac bones, and there is hypoplasia of the head of the radius, and this is associated clinically by dysplasia of the nails, and this is very specific of nail patella syndrome or Fong disease. If we have single exostosis, that's a common thing, you find it, and this is a benign finding, you should not be worried about it. But if it is a multiple exostosis, with the typical picture that those exostoses are going away from the joint, and it is affecting almost multiple bones like this, and you should think about diaphyseal eclasis or multiple exostosis, and 10% can go into malignancy. And if we are worried one of them is growing faster, we should do MRI and see thickness of that cartilage. Lucent lesion in the phalanges, which is causing a little bit of expensile, it is very specific of enchondroma. Other bones can be associated with this enchondroma and could be severe as this, which is causing severe expansion of the bones. And this is Euler disease if it is not associated with hemangioma and calcification, and it is Mofushi if it is associated with calcification. Now we come to diseases which we are not very clever with them. We can describe the terminology, but we cannot say that this is the specific bone dysplasia similar to what we were before. Look for this one. If you look to this metaphyseal margin, it is irregular metaphyseal margin, but it is not rictus because the margin is sclerotic, and this looks like a bad metaphysis, so it is metaphyseal chondrodysplasia of some sort, could be mild, moderate, or severe, but could be associated with other bone dysplasias. So we just describe it for them and say that this is the most probable. If we have the epiphysis, which is flattened, deformed, and abnormal in shape, this could be epiphyseal, multiple epiphyseal dysplasia, and see when the children are grown, still it is a small, flattened, and they can go in degenerative changes very easily. So what we need actually to learn our radiology well. Those specific disease, we have no excuse, but really to find them, and those that we cannot reach a final diagnosis, we need the help of a clinician, genetic counseling, and we need to help each other. We need a Saudi Society of Bone Dysplasia, that we share our ideas, we meet together, we learn from each other. Thank you.
We'll leave the discussion at the end of the lecture. The next lecture with Dr. Khalid again, easy approach to renal cystic disease.
Okay, renal cystic disease. It also was a confusing issue for me for a while, until I started to have a system in my brain, which I'm going to share it with you. I'm going to speak about all these diseases: autosomal recessive polycystic kidney disease, autosomal dominant polycystic disease, cystic dysplastic. Don't worry about all these names. Try to analyze those names in your brain. You will find that we are going to come to a joint ground. If it is associated, if this renal cystic disease is associated with a syndrome, end-stage renal disease, simple cyst, if it is associated with a tumor, or it is associated with syndromes and glomerulocystic disease and nephronophthiasis. So autosomal recessive polycystic kidney disease, as the name said, autosomal recessive. And those kidneys are large. You don't see cyst when you do ultrasound. You are going to see dilated collecting ducts. So it is ductasia of the collecting ducts. It is not cyst. And it can be associated with biliary dysgenesis. What is the natural history? Those kids are going into liver failure or renal failure in the first or second decade. The ultrasound picture, large kidneys, very echogenic kidneys, smooth outline, and you are going to see echogenic interfaces in the parenchyma due to the tiny cyst, which usually we cannot resolve it, that it is a cyst. Those small cysts may grow when the child is growing up. If we do a CT scan for these kids, we are going to see the large kidneys, and we are going to see streaking of contrast, which is going to the medulla of the kidneys, which is giving a spoke wheel-like appearance. This is the picture which we are going to see it in those kids. There is loss of corticomedullary differentiation, echogenic kidneys, and there is no definite cyst you can see. Similar picture when the child grows up to the age of 7 years, and you can see that the liver is starting to have cirrhotic changes. By the age of 21 years, usually they are either in liver or renal failure. And this is the same kidney in different ages, 2, 5, 8, 12. The kidney hardly has been changed. You cannot see much of cyst changes, and it is just echogenic large kidney. If you look to this kidney by the age of 13, yes, there is a small cyst has been developed, few millimeter cyst, and the kidney is almost the same as in the neonatal period. We could be associated with biliary dysgenesis like Caroli's disease associated with autosomal recessive polycystic kidney disease. In the neonate, you may image both kidneys if you look coronally, and you can see a kidney like this. Echogenic kidney, there is no differentiation between cortex medulla, and there is no cyst. Autosomal recessive polycystic kidney disease. If you have a high resolution probe, you can look to the cortex and you can see the tubular lucency in the cortex, and this is the ductasia or the dilatation of the ducts within the cortex. This is old film of IVU. We don't do IVU anymore for the children. This is obsolete examination now. But if we look to this image and look to the parenchyma of those kidneys, you are going to see radiating lines with the contrast coming from the collecting system. And this is the dilated ducts which we are talking about. This is the picture you are going to see with the CT, which is large kidneys, spoke wheel-like appearance due to this tubular things which contain the contrast. This is another example of autosomal recessive polycystic kidney disease associated with Caroli's disease. If we look to this slide, MRI, which is showing big kidneys, lobulated, a little bit appearance, but this is fatty lobulation. It is not due to the disease itself. And if you look to the liver, there is Caroli's disease. Autosomal dominant polycystic kidney disease is a little bit reverse to that what we have seen in autosomal recessive. It is large kidneys, lobulated kidneys. There are cysts from day one, and those cysts are going to grow with the age, and this child will have renal failure by the third, fourth decade of life. The natural history, renal failure by the age of the fourth decade, hypertension, hematuria. Ultrasound, large kidney, multiple cysts of different sizes, and the renal parenchyma between the cysts looks normal. Those cysts will go bigger with the age, and we can have cysts in the liver, pancreas, spleen, lungs, ovaries, testicles. And IVU, which is the old thing, there is no more IVU for children. If we need something like IVU, we go for MRU. But IVU in the past were showing that the cysts are displacing the collecting system, which is giving a spider leg-like appearance. This is the picture we are going to see in a child with multiple cysts of different sizes. And those cysts will grow with the age. And if you look to this IVU, you can see the spreading of the major and minor calyces, which is giving a spider leg-like appearance. And it can be associated with multiple cysts in the liver. Cystic dysplastic kidneys. It contains this group. The commonest one, multicystic dysplastic kidney, or could be obstructive cystic dysplastic, or could be dysplastic or hypoplastic. If you analyze the names, it is just a description of what is going on. I'm going to jump to what we call it the formation of the kidney. So there is the embryogenesis of the kidney. By the age of 22 days, there will be two pairs of pronephros. Remember those three names: pronephros, mesonephros, metanephros. That's all you need. So this pair of pronephros, by the age of 22 days, it will descend down to join the cloaca. Then it is called mesonephros. By the age of 5 weeks, there is a tubular structure called urethric bud come out from this mesonephros to join the metanephros. The other name for it, metanephrogenic or metanephros plastema. So if this urethric bud joined the metanephros, this will stimulate the metanephros for formation of the tubules. Those tubules will not be formed unless the urethric bud is joining the metanephros. So this is why you find in multicystic dysplastic kidney that the pathogenesis is the urethric bud has not reached the metanephros, the metanephric plastema. It did not reach it, so thus did not stimulate the formation of the tubules, and that's why the metanephros will go into a degeneration into cystic changes. It is usually unilateral, and if it is bilateral, it is incompatible with life, and that kidney with multicystic dysplastic changes will have no function. What is the natural history? This kidney will tell you, leave me alone. Multicystic dysplastic kidney will involute, go smaller by those cysts, and it will cause no complication. So please don't remove those kidneys. No need for nephrectomy for multicystic dysplastic kidney. The kidneys, the multicystic dysplastic kidney is large, multiple cysts of different sizes. There is no renal parenchyma because the urethric bud did not join the metanephros, so that metanephros has gone into degeneration and did not develop into normal renal parenchyma. And there is no collecting system. This is the picture of multicystic dysplastic kidney. You'll find big kidney with multiple cysts. The cysts have different sizes, and there is absence of normal renal parenchyma. The other kidney is a normal kidney here. The left kidney has normal parenchyma. If you look to the nuclear scan, you see that there is no function in that right kidney. Always the other kidney is normal? No. If we look to the left kidney, it has a multicystic dysplastic kidney, which is the lower one. If we look to the upper one, there is hydronephrosis. And the shape of the renal pelvis is a rounded shape renal pelvis. Always when the renal pelvis is more dilated than the calyces and has a rounded shape, we should raise the suspicion of UPJ obstruction, uretero-pelvic junction obstruction. If we look to the upper one, typical picture of multicystic dysplastic kidney. If we look to the lower one, there is mild hydronephrosis, hydroureter, and you can see that ureter is joining the urinary bladder. So there is vesicular reflux in the other kidney, and the other kidney is having the multicystic dysplastic picture, which is typical of what we have seen. The right kidney is having this multicystic dysplastic picture, and the other kidney is having this picture of hydronephrosis. VCUG was done for this child, and you can see the ureteric bud. It has been cannularized in this child. It has not reached the kidney, and this is the typical of ureteric bud on the right side. Obstructive type of cystic dysplastic kidney. What we mean by that? We mean that there is obstruction. If it is a complete obstruction, the kidney will be damaged. But if it is a significant obstruction, like UPG obstruction or obstruction due to any other causes, it will cause cystic changes in the parenchyma of those kidneys. So the kidney will be normal or small in size. There will be a few millimeter cyst, and there is normal parenchyma between those cysts, and hydronephrosis is a must, so you know that this is obstructive kidney. This is one example. You can see there's hydronephrosis, and there is a multiple small cyst within the parenchyma, so most probably this is obstructive type of cystic dysplastic kidney. And this is another example with the hydronephrosis and the small cyst within the parenchyma. If it is a bilateral hypoplastic dysplastic kidney, this is called Potter's syndrome, and this is a specific syndrome. Both kidneys has gone into dysplasia, and both kidneys are small, and both kidneys contain cyst. And this is the typical picture of we see to the Potter syndrome. And because there is oligohydramnios, you will find the chest is constricted, small chest, and the kidneys are small in size with multiple small few millimeter cysts within the parenchyma. If it is a unilateral hypoplastic dysplastic kidney, similar to what we see in the bilateral Potter syndrome, but it is unilateral, this could be an isolated phenomena, not a syndromatic, and that kidney will be small, echogenic, multiple small cysts. The other kidney will have compensatory hypertrophy. And this is example. If you look to the upper row of the images, you can see very small echogenic kidney with cyst. If you look to the lower row, you see the compensatory hypertrophy of the other kidney. In this stage renal disease, the kidneys become small, scarred. If the child is on hemodialysis, they can develop some cyst within the parenchyma. So this is the cystic disease which is associated with end-stage renal disease and with hemodialysis. Renal cystic disease associated with syndromes. Zellweger, you have seen it in the previous presentation, tuberous sclerosis, and von Hippel-Lindau disease. If you see this picture, echogenic, rounded lesions, single or multiple within the kidneys, and can be associated with tiny cyst between them, or could be associated with aneurysm or pseudoaneurysm. This could be the only presentation for the child for tuberous sclerosis. This picture, you have seen it before, and there is multiple small cysts of a few millimeters associated with cyst in the brain, associated with scimitar-like calcification in the patella, and this is typical of Zellweger syndrome. Simple cyst is rare in children, but it can happen. And usually it is very small, few millimeter at birth. Then it will grow in the first 10 years of life. Then it will stay the same. Complication is very rare in those simple cysts. How we can say that this is a simple cyst? Be sure that this is a definite diagnosis. If you see that the cyst is a clear margin, very smooth margin, very clear fluid within it, there is no connection to the collecting system, most probably this is a simple cyst. What is the differential diagnosis of that cyst? It could be hydrocalyx, it could be calyceal diverticulum, or could be a complex cyst. This cyst the margin is not very smooth like the first one, not very rounded. So is it a simple cyst? You should raise the suspicion. You don't want to be losing other diagnosis. You may do MRI and see that. It looks like a clean cyst. There is no nodule, there is no septation, there is nothing to worry about, but it is not really a very round, smooth cyst. We followed this child from age 5 to 8 years, and the cyst is getting smaller. It is a benign cyst, but it is not your call. You should raise the suspicion that this is not a very simple cyst. If you see that the cyst has a heart-like appearance, probably it is not a simple cyst. It could be hydrocalyx. If you see the cyst has some septum, if you look to the lower image on the right side, that septum is thin and smooth. So if you see a cyst with a septum like that, it could be calyceal diverticulum. How we can be sure that this is calyceal diverticulum? Calyceal diverticulum is connected to the calyx. Sometimes you see that there is what we call milk of calcium, fluid, and if you will have old images like those, you may see the fluid of the milk of the calcium in the decubitus image. Those calyceal diverticulum, if you will do IVU in the past, those can be filled with the contrast like the calyces. But today, if you have a CT scan and you are worried that this could be not a simple cyst or could be calyceal diverticulum, delayed images will show that the contrast has gone into this calyceal diverticulum. If we see a cyst similar to that, which is having thick septation, irregular, I should not be happy to call it calyceal diverticulum. This could be a malignant lesion. And if you see septated cyst like that, also you should be worried that could be a malignant lesion. Glomerular cystic disease. What does it mean? The dilatation of the Bowman capsule of the glomeruli is going to be ballooned and dilated. This is not a specific disease, but could be associated with all the other renal cystic disease which we have spoken about. The ultrasound will show that there is a tiny cyst like blisters, which is coming from the surface of the kidneys. They are a few millimeters, and usually they are not associated with renal failure unless it is associated with other disease, renal cystic disease. This is the typical picture of a glomerular cystic disease. Tiny, few millimeter coming out of the surface like blisters. Another example of a glomerular cystic disease. This is the interesting entity, nephronophthiasis, medullary cystic disease. It is autosomal recessive, associated with polyuria polydipsia, and they go into end-stage renal disease in the second decade. This diagnosis is missed by a lot of radiologists. Nephronophthiasis, the kidneys are normal in size. They have echogenic pyramids similar to nephrocalcinosis. So most of those children has missed as nephrocarcinosis. There is no cyst to see. The cysts are very tiny that cannot be resolved by the ultrasound today, so you see it as multiple echogenicity, that's why diagnosed wrongly as nephrocarcinosis. It may be associated with liver disease, liver cirrhosis, or biliary duct disease like Caroli's disease. And this is one example. If you look to the first row of ultrasound, you will say, well, this is typical of nephrocarcinosis. You have to be sure. If you will go to CT scan, there is no calcification, so it is not nephrocarcinosis. If you look to the image beside it, that when contrast has come to the collecting system, you see that those pyramids has no contrast. It means that there is something preventing contrast to go to the pyramids, and this, if you look to the images of the MRI, and you can see that after gadolinium, there is typical in this T1, there is a tiny cyst within the pyramids. And this is nephronophthiasis, typical diagnosis. Another example, the pyramids are very echogenic. It looks like nephrocarcinosis. CT scan, there is no nephrocalcinosis. Look to the delayed images of the CT scan, which is in the middle, and look to the images of the coronary format. You see that the medulla has not been opacified by this contrast, and there is a multiple small, tiny, low attenuation due to the small cyst. This is another example, and if you look to the images of the CT scan, again, the pyramids are not enhanced with the contrast, nephronophthiasis. How we differentiate it from this? This is nephrocalcinosis. Nephrocalcinosis will start like a ring-like echogenicity in the pyramids. Then the whole pyramid will be filled with those echogenicity and forming this picture of nephrocalcinosis, which can have the acoustic shadowing, and this is the typical of nephrocalcinosis. Look to this echogenicity in the pyramids, and look to this echogenicity in the pyramid in nephronophthiasis. This is like a dirty echogenicity due to the intersurface of those tiny cysts, which cannot be resolved very clearly by the ultrasound. But in nephrocalcinosis is a very well-defined echogenicity due to the calcification. So in summary, if we have bilateral big kidneys with cyst, it is either autosomal recessive or autosomal dominant polycystic kidney disease. If we have small kidneys with cyst, it is either hypoplastic dysplastic kidney. If it is bilateral, it is Potter syndrome, or we are dealing with end-stage renal disease. If we have only one kidney, which is large and with multiple cysts, multicystic dysplastic kidney is the commonest thing, or could be a tumor, cystic nephroma, or mesoplastic nephroma. If we have kidneys which is normal size with the tiny cyst, glomerulocystic disease, nephronophthiasis, Zellweger, obstructive nephropathy, tuberous sclerosis, von Hippel-Lindau disease. Thank you very much.
Thanks a lot, Dr. Khalid, for the comprehensive and nice presentation. The next speaker, Dr. Sattam Linjawi. He is a professor of radiology in College of Medicine at King Saud bin Abdulaziz University for Health Science in Jeddah. His topic, normal and abnormal pediatric brain. Please, Prof. Sattam.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. I would like to start by thanking the organizing committee for the kind invitation and the generous hospitality. I'm not going to go into a lot of details because this, I do want this to turn out to be a sort of a dry subject. The aim is basically to highlight the main landmarks, radiological landmarks in normal pediatric and neonatal and pediatric brain development in terms of the sulci, the gyri, as well as the myelination. And then also to touch some of the important issues and bases in significant abnormalities and common abnormalities, particularly in the form of ischemia, the pathogenesis of different common neonatal brain abnormalities, and just a quick touch on the dysmyelitic disorders. So let's start, and we have to start by just having a quick review of the normal white matter constituents in terms of cellular formation as well as the biochemical components. It's basically formed of the neuronal axons and the supportive connective tissue, which is the glial tissue, the neuroglial. The neuroglial tissue is primarily of two main types of cells, the astrocytes, which basically repair the damage that occur in the regular growth and tear and wear processes that occur in the brain, while the oligodendrocytes produce the myelin. The function of the stroma of the brain, the parenchyma, is in somewhat supportive to the neurons in terms of structural support, as well as being a media to conduct nutrients, oxygen, glucose, formation of neurotransmitters, regulating the neurotransmitter function, etc. In the peripheral nervous system, Schwann cells are the ones responsible for the myelin production, while in the central nervous system, it's actually the oligodendrocytes. And these oligodendrocytes have rather flat axons, not cylindrical axons. And what they do is that the axons of the oligodendrocytes extend and wrap around the axons of the neurons. Now, so each axon of any neuron is wrapped around by several oligodendrocytes. And between these areas of different oligodendrocytes wrap around areas, we have areas of deficient myelin. These are obviously in micrometers or maybe nanometers. They're tiny, tiny ones. And they're known as the nodes of Renvier. So basically, you've got the axon, and the axon is wrapped around by, in a roll shape, by the flat axons of the oligodendrocytes. And this is how the myelin is covering the axons of the neurons. If you look into the chemical components, and this is in general, but particularly related to the white matter, it is primarily lipid. And it is formed by 40% by phospholipid, 30% by galactolipids, and then cholesterol. Obviously, there is a large content of protein, which is the proteolipids as well. Now, the water and protein/lipid contents vary between the gray matter and the white matter, with the white matter having more lipid and less water, and vice versa in the gray matter. In general, there are a lot of words and terms that are being used. And although some of us may think that these can be used exchangeably, however, they should not. Myelin or myelination is the normal process of deposition of normal myelin, and this is the normal physiological process that occurs as part of the maturation of the white matter. Demyelination is the loss of the normal myelin that has already been formed. And this is frequently seen in whether primarily or secondary, but in cases of multiple sclerosis, as well as post-infectious processes like ADM. Dysmyelination is actually lack of normal myelin formation. It is now the difference is in demyelination, normal myelin has been formed and then it somehow decayed because of a pathological process. While in dysmyelination, it has not been formed well from the beginning. It is lack of normal myelination. Now, retarded myelination is delaying or delayed formation, delayed deposition of normal myelin, and that can occur due to several pathological processes, among which is malnutrition and hormonal imbalance, infections, etc. So whatever myelin has been formed is normal, but it is rather delayed to the normal chronological age of the neonate. Amyelination or hypomyelination is lack or too little myelin. The amount of myelin is little, and that's a permanent deficiency. It remains of normal myelin, but less than what is normally required. Now, remyelination is the repair process that usually occurs after recovery from infections, recovery from long-standing malnutrition status, recovery from MS. However, the redeposited or newly formed myelin is never as normal as it should have been in the first place. So having these terms clear in mind are very important. In the sort of, as a general radiologist, when you're looking at pediatric brain, it becomes a difficult task to know what is the normal part and what is the abnormal part when it comes to the myelin if you're not familiar with the normal milestones and the usual progression of myelin formation in the brain. So advice number 1 is that you have to know your myelination milestones. Now, you don't have to memorize them. They're written in books. They're widely available on the internet. Have them sort of ready, accessible, if you are reading brain MRI for neonates as part of your regular tasks in your hospital. Then categorize the abnormality if you see an abnormality, whether it is a basal ganglia, or is it a brain stem, is it a white matter? If it is in the white matter, is it a peripheral zone or is it a central zone? Does it involve gray matter as well? And then don't forget that the most crucial part of studying any case is to compare with the previous. Frequently, you cannot make a diagnosis just from looking at the images that are presented to you without knowing the history and without having access to previous images. So be liberal in requesting previous images to compare with. Remember also, when it's too late, it's too late. When the child is presented to you at the age of 9, while the pathological process has started in the neonatal period, all what you have is a burnt out Brune-like brain, a shrunken brain tissue that is basically atrophic, dystrophic, and diseased. And you cannot tell what's the process because it's just too late. And in this situation, it would not be possible to give a diagnosis. Finally, and probably most important, is not to be disappointed if you cannot pinpoint the exact name of the disease, because these are complicated diseases that have many considerations, whether anatomic as well as biochemical basis. Frequently, they cannot be diagnosed from radiological imaging only, and it's basically a constellation of clinical findings, extensive biochemical studies, as well as radiological images. So if you cannot pinpoint the exact name of the disease, that's okay. And majority of the time, we may not be able to do so. In MRI, when you come to evaluating neonatal brain, stick to the basics. Stick to T1 and T2. Fancy images are always nice to look at. Fancy sequences are always nice to use. However, they may actually end in these situations leading you to a wrong diagnosis or wrong assumption. Stick to T1 and T2. And optimize your sequences. Remember that spin echo has a higher magnetic susceptibility than fast spin echo. So that fast spin echo is less sensitive to hemorrhage and calcification. Remember that, and I will tell you why in a minute, in the first 6 to 9 months of life, T1 is better for evaluation of white and gray matter differentiation than T2. While in the second half of the year, between 6 to 12 months, it's the opposite. So by evaluating T1 and T2 consequently together and looking at previous images, you're most likely going to be able to identify the abnormality, whether this brain is normal or abnormal, and identify where the abnormality is, if it is there. In the neonatal brain, unmyelinated fibers lack fat, so they are dark on T1 and they are bright on T2, and this process reverses gradually as brain myelination progresses, and water content decreases. There are general rules. Myelination starts from the center to the periphery, from posterior to anterior, and from the bottom to the top. So at birth, you expect the brain stem, at least the posterior part of the brain stem, as well as the majority of the cerebellar deep white matter, to be myelinated. Then there's the posterior limb of the internal capsule, the splenium of before the anterior limb, the splenium of the corpus callosum before the genu, the periventricular white matter before the U fibers, and the occipital lobes before the frontal lobes. So it is from bottom to top, from back to front, from inside to outside. And this has been documented stage by stage in so many textbooks. Van der Nab textbook in dysmyetic disorders is one of the major references, and you can actually plot them in a table that you can actually print next to your reading station, and you can review every now and then what is being myelinated and at what stage. Important to identify that before the age of 36 weeks, which is the sort of the cut margin between premature and full pregnancy, full-term pregnancy, between below 36 weeks, the posterior limb of the internal capsule is unmyelinated, so it is dark. And in order to call it dark or bright, you have to compare to another intrinsic tissue, and we compare here to the basal ganglia. So before 36 weeks, it is unmyelinated. And it gets started, the myelination starts from 37 weeks. So you can see that the posterior limbs start picking up higher signal intensity from 37 weeks upward. This is very important because early ischemic changes in the perinatal, secondary to perinatal hypoxic ischemic event will affect this area and will show you deficiency of myelination, so that the myelination in the posterior limb will not happen as early as it should be, and that's one of the early signs of hypoxic ischemic events and injuries. So this is just a series. The top row is a T1, the bottom row is a T2, and you can follow up the myelination within the different structures. At 1 month, you see myelination in the internal capsule, primarily posterior limb rather more than the anterior limb. Then you start progressing by 3 months into the anterior limb as well as the splenium of the corpus callosum, to be followed later by the genu of the corpus callosum, and more volume and more myelination into the occipital lobes. Finally, the arborization pattern of normal myelination starts developing into the frontal lobes. And on the second row, the T2 weighted images show corresponding images at a later stage, and you can see the clear progression of myelination between 6 to 9 months in the corpus callosum, and then more deposition of white matter, myelin, into the deep white matter of the corona radiata, and eventually the subcortical U fibers are being myelinated by 24 months, which is reaching the normal brain maturity. So at 1 week old infant, you can see that the increased signal intensity within the posterior limb of the internal capsule, indicating normal myelination, with the corresponding decreased signal intensity on the T2 weighted image. Then by 30 weeks, you can see that you get more myelination into the occipital lobes, and eventually by 3 years, you have an adult pattern of myelination within the brain. Basically, this is the basics of understanding normal myelination pattern and progression. As I said, you don't have to memorize it. Just understand that this is an active, ongoing process. It's not a one step. It's not all or none. It's a continuous process that occurs, and it goes through different stages at different times. Have this in mind, print it, copy it, draw it, and stick it next to your monitor if you're reading neonatal brain, and refer to it every now and then. As I said, fancy imaging is always nice to use, but plays really limited role out of research fields. Isotropy using tensor imaging is important, and it basically identifies the development of tracts, which is formed by the development of the myelin. In the gray matter and in the unmyelinated white matter, water molecules do not have a directional flow. They can flow in any direction, and that's called isotropy. As myelin is being developed, tracts are being directed, so you have certain directions for certain tracts, so the water flow will be directed in a certain way rather being diffused in all directions. So you lose your isotropy and becomes anisotropic. And that's basically the basic of tensor imaging. So by imaging the brain, looking for tracts, and if you can see the development of a directional water molecule flow, then you know that myelin is progressing. And if there is no directional flow, then it is isotropic flow, then myelin is deficient. This is just the basic concept of it, and you can build on that. But we do not usually use it for purposes of myelin evaluation. So it's an active process. Look at the previous, request follow-up. Sulcation and gyration is also another interesting part of brain development because it also has its own milestones and stages that it goes through. Sulcation in the premature and the neonatal brain is not fully developed and develops in a predicted manner. 15 weeks of gestation, there's only the interhemispheric fissure. By 18 weeks, the insula and the lateral dips, which basically the Sylvian fissures or lateral sulci start developing. The parieto-occipital fissure and the calcarine fissure, as well as the Rolandic fissure, start appearing by 23 to 25 weeks. And just before 29 to 30 weeks, the frontal and the temporal opercula covering the Sylvian fissure start appearing. And if you plot that in sort of in a diagrammatic way, the brain starts by being smooth and flat. Then the sulci start developing as short, simple, shallow indentations. Gradually, these indentations become longer and narrower, and the gyri in between become deeper and slightly less wide. And that goes through different phases or different stages of 5 stages, ending with a complex pattern of branching sulci and a cauliflower appearance of the gyri. When you count the gyri, and we say that the frontal lobe has 3 gyri, the superior, middle, and inferior, and the temporal, superior, middle, and inferior. We count the stem of the gyrus, not the surface of the gyrus, because one stem can give you to multiple gyri, very much like the cauliflower appearance. So this is how the brain develops over 23 to 27, 20 to 35 weeks, showing you the progression of the complexity of the cortical gyri and sulci. Okay, why certain diseases and certain tissues affect more than others? Now, those who read brain MRI, neonatal brain MRI, and deal with complicated cases will come to realize that certain diseases or some diseases that have no common pathological entities among them affect similar areas. For instance, LAYS, connectors, and hypoxia all affect basal ganglia, primarily the globi pallidi, but also may affect the putamen as well. Although, if you go into the pathological processes in LAYS, connectors, and hypoxia, they're quite different. Nevertheless, the area that is being affected is the same. Vice versa, sometimes similar diseases, carbon monoxide poisoning, and hypoxia and suffocation may affect different areas, although the essence of all these 3 is hypoxia. So similar diseases may have different distribution, and different diseases may have similar distribution. And the reason for this is not known. However, it could be due to a stimulation of a common pathway that is being used by different diseases, and it ends with a certain appearance. So we don't know why, but we also know that it has to do with cellular vulnerability. The different cortical layers of the brain cortex, as well as the basal ganglia, have different vulnerability to ischemia and to toxic material. Some cells can sustain hypoxia and sustain toxins more than others, while others are more susceptible for early affection. The bottom line is we don't know why, but this could be one of the explanations. What do we use? Do we use ultrasound, CT, or MRI? Well, all are valid. Each one has its own advantage and own disadvantage. Cranial sonography is convenient, non-invasive, relatively low cost. You can repeat it anytime you want. However, although it is sensitive for hemorrhage and hydrocephalus, it is not sensitive for parenchymal abnormalities. It may miss early changes. And the windows, although through the fontanelles, different fontanelles and sutures that are open is accessible. However, it never gives you full coverage of all areas of the brain, and it is very much operator dependent. CT is the least sensitive among all because of its poor gray-white matter differentiation at this age due to the high water content of the brain. Nevertheless, it has high sensitivity for hemorrhage, and obviously in cases of suspected child abuse, for fractures as well. So I guess MRI would be the most sensitive modality, particularly if you stick to the basics, evaluating gray matter and white matter maturity and progression using T1 and T2. Remember that spin echo would be better than fast spin echo. However, most of the machines and what is available in the market currently would oblige you to use fast spin echo in your routine practice. Why in ischemia, in a neonate of an immature brain, have different distribution of infarction than the neonate who was born after a full term? Because the premature brain has a different blood supply mechanism than the mature brain. In the immature brain, the blood supply comes from the cortex and goes deep to the periventricular area. The most active area is the periventricular area. The caudate-thalamic groove, the germinal matrix, that's where the gray matter is being formed, and then it migrates to the periphery. So blood supply comes from outside and penetrates to the periventricular region. Hence, the ischemia tends to be in that area. In the mature brain, blood supply changes, and you get dual blood supply from deep, from the periventricular region, as well as from the cortex. So the zone of ischemia and zone of deficiency moves outward in the deep white matter rather than in the periventricular white matter. And this is why you get the different distribution in the areas of infarction, whether the baby is a mature or an immature brain. Like in this case, where you have ischemia affecting the basal ganglia primarily and the occipital lobes, and you put the normal for comparison. The degree of infarction and the ischemia is also dependent on the level of the brain maturation, the severity of the process, the degree of the hypotension, and the duration of the ischemia. Eventually, you end with the classic PVL appearance with the Swiss cheese holes that are in the periventricular white matter and the scalloping of the outer margins of the enlarged ventricles and the generalized reduction of the white matter. Two last words on dysmyelitic disorders. I'm not going to talk about this extensively. However, you get an extensive list of dysmyelitic disorders, and it is very difficult to memorize them. It is very difficult to pinpoint each time which disease is it. The most important is to go back and to categorize where the abnormality is. Is it a gray matter or is it a white matter? Does it involve the brain stem? Does it involve gray matter and white matter? If it is white matter, is it peripheral or central? And sometimes you come across classic cases like these three cases of Leigh disease, where you have the classic high signal intensity in the putamina as well as the head of the caudates with the involvement of the brain stem and the thalami. You may have the glutaric aciduria with the classic wide sylvian fissures and bilateral arachnoid cysts beside the involvement of the basal ganglia. And you may have the maple syrup, which is rather common in our community, which gives you the intense increased signal intensity of the brain stem on diffusion that simulates an active angry process of acute infarction, although it is not an infarction itself, but it gives you a swollen, restricted diffusion in the brain stem. Sometimes characteristic cases like the metachromatic leukodystrophy with the classic appearance of the sort of tigroid striation of the white matter, or the adrenal leukodystrophy with the classic involvement of the corpus callosum and the occipital lobes. Rarely you get the classic appearance of the peripheral white matter involvement like the Sayre-Curran syndrome, which is frequently accompanied with the ophthalmoplegia and ECG changes of bundle block. What I intended to say from my presentation here is to give you a broad sort of outline of how do you evaluate normal appearance and normal progression and development of the neonatal brain over different stages, including the white matter myelination, the sulcation and the myelination. How do you identify the abnormalities and characterize them? And then always remember, these cases are difficult. Stick to the basics and do not be disappointed if you cannot pinpoint the diagnosis. Thank you very much.
Thanks, Prof. Sattam, for the nice presentation, and again with Dr. Khalid Al-Mani for the last lecture in the first session. The lecture, Finding Cystourethrogram, it's easy or difficult in children.
Bismillah ar-Rahman ar-Rahim. I think everybody of us think he can do a good job with the VCUG. It is just a procedure, fluoroscopic procedure to put contrast in the urinary bladder. Then we start to study the urinary bladder, shape, capacity, function, and see if there is reflux, and see the urethra. I think it is deeper than this. What is the indication of doing VCUG in children? Boys for the first urinary tract infection, girls if they have recurrent urinary tract infection, pyelonephritis, if there is hydronephrosis by ultrasound, if the VCUG was treated before surgically and you want to check if it is successful, and if there is urinary bladder outlet obstruction, neurogenic bladder, stress incontinence, and before transplant. What is the contraindication? Contraindication if there is urinary tract infection, if there is allergy to contrast media, or there is rupture of urethra or bladder. And these are some tips how you can handle a child. You need a friendly atmosphere. You need trained people how to handle a child. You need experienced person to do catheterization. If you don't want to do it yourself, please train somebody not to give the child hard time and cause pain. If the patient has intermittent catheterization, which is done by himself or by the mother or somebody else, let that person do the catheterization in front of you and learn him how to do a septic technique. Don't keep the room dark. The children are afraid of dark rooms. Always we do, almost always we use feeding tubes. Follis catheter, we use it only in certain instances. And I myself add some concentrated water-soluble contrast when I have history of severe hydronephrosis or there is a neurogenic bladder, because this dilated collecting system is filled with urine. And in order to opacify this urine, you need more than cystochondria in order to see it without delayed procedure. We give the contrast by drip. We don't give it by injection. This is less harmful. And in severe hydronephrosis, I may keep the child that side down for a while, because contrast is heavier than urine. It will go to this dilated collecting system and you are going to see it easier and faster. Don't remove the catheter until the child starts micturition. If you remove it, you are going to radiate the child for a long period and he's not going to micturate. In the neonate, you find the children, as soon as you put the contrast, they empty the bladder. So you may do multiple cycles to be sure that there is no reflux. And we have said that we don't remove the catheter until the child starts micturition. And you'll find those neonate, they start micturition, then they stop. And they are not going to micturate again. Don't radiate them more. They lost the urge for micturition. If you saw the urethra, that's enough. Stop the examination. Sometimes what you are seeing is not a residual urine. It is just the child has lost the urge to pass more urine. Follis catheter, we use it when there is continuous leakage from the urethra or suprapubic opening if the child has one. What about urinary bladder? Urinary bladder capacity is measured by this. Age by years plus 2 multiplied by 30. Urinary bladder, we have to wash the shape of that urinary bladder. Normal urinary bladder will look like a balloon and it will contract slowly like a balloon until it empties completely. This is normal detrusor muscle contraction. A bladder duplication, Usually it is in the sagittal plane, and one ureter will go towards duplication and could be partial or complete. This is almost complete duplication of the urinary bladder. Diverticulum. It is a protrusion of the mucosa to the outside through a defect in the muscles, and a single diverticulum like Hutch diverticulum. Hutch diverticulum is the diverticulum which is at the vesico-ureteric junction and can be associated with reflux. Multiple diverticuli, we see it in urogenital bladder, you can see it in bladder outlet obstruction, and you can see it in syndromes like Menkes or cutis laxa. Hutch diverticulum is the commonest one. It is at the vesico-ureteric junction, could be associated with reflux, and it may cause bladder outlet obstruction. You can see it by VCUG, ultrasound, and IVU is history now. This is the shape of Hutch diverticulum, and this is a Hutch diverticulum with reflux. Multiple diverticuli, as we said, we can see it in the neurogenic bladder or outlet obstruction. This is a neurogenic bladder, which you can see a multiple diverticuli of different sizes, and those diverticuli could be the cause of stagnation of urine, so they may cause stones. Urachus is the connection of the bladder to the umbilicus in utero, usually closed by birth. What is the anomaly we expect from it? If it continue opening from the bladder to the umbilicus, this is fistula, urachal fistula. If it is open to the umbilicus, this is a sinus, urachal sinus. If it is open to the bladder only, that will be urachal diverticulum. But if it is only cyst, it's not open to the bladder or to the umbilicus, this is urachal cyst. And this is a prone-belly child, and if you look to the shape of the collecting system and these things, the most important here is the urachal diverticulum. You can see projection from the bladder to the outside. It is blind. It is a urachal diverticulum. This one, if you look to the image down, you can see that this urachus is having a tiny fistula which is going to the umbilicus, urachal fistula. Bladder exstrophy or ectopia vesica, when the anterior wall of the bladder is opening to the abdominal wall. In a plain film, always you are going to see separation of the symphysis pubis, and this is diagnostic of ectopia vesica. And what you are seeing from those images, this is a repaired bladder. Repaired bladder will be small, abnormal shape, unless it will have augmentation, then it will be large, and always the urethra is abnormal shape due to the repair. This is a bladder exstrophy, widening of the symphysis, abnormal shaped bladder associated with reflux. In the lower images, you can see that we have used Foley's catheter in order to stop the leak in this ectopia vesica, and you can see a rounded lucency adjacent to the balloon of the Foley's catheter, and that was injection of Deflux to prevent reflux, but it was not successful. This is another example of ectopia vesica, separation of the symphysis pubis, and this is augmented bladder. That's why you see it abnormal shape, and there is a grade 1 reflux. In this case, you can see that there is a calculus has been developed with this augmented bladder. If you are doing ultrasound and VCUG in the same day, please do ultrasound before VCUG. Why? This is an example. If you look to the ultrasound, you are seeing an echogenic things within the upper calyces. That air has been refluxed due to the VCUG, and it may give you a wrong impression that there is a pathology like a stone or calcification within that area. So please do ultrasound before you do VCUG always. Ureterocele. What is ureterocele? A cystic dilatation of the terminal ureter. Could be simple if it is in the normal position of the vesico-ureteric junction, or could be ectopic and causing outlet obstruction of the bladder. Ultrasound will show it, VCUG will show it, and IVU is just history now. Full bladder may press on that ureterocele and may collapse it or even push it outside, herniating outside the bladder wall. This is an example of IVU from the old time, which showed that there is a rounded filling defect on the left side of the urinary bladder due to ureterocele. This is a large ureterocele which is causing bladder outlet obstruction. and this is the urethrocoel. You are going to see it by ultrasound. Sometimes you do ultrasound, you may not see the urethrocoel in the beginning. If you are thinking of urethrocoel, or you have history, or you have a VCUG which has showed urethrocoel, just wait for a while. It will be filled with urine, and it will be like a copper head which is projecting within the urinary bladder. This is another example which is showing hydroureter, urethrocoel, and there is a small calculus within this urethrocoel. Neurogenic bladder, congenital due to myelomeningocele, myelodysplasia, diastomatomyelia, or sacral agenesis, or could be acquired due to trauma or tumor within the spinal cord. Classic picture, we see in the plain film that there is dystrophism of the vertebrae, and those neurogenic bladder, usually small, but could be normal or could be large in size, has a thickened wall, trabeculation, and multiple diverticuli, and there is no contraction. We remember how the urinary bladder contracts like a balloon. This will show no contraction. What does it mean? They can have incontinence, overflow, but those children, some of them is very smart. Some of them is using their abdominal muscle, and they can empty the bladder completely. Some of them are using their hands to empty the bladder. VCUG ultrasound are diagnostic and can be associated with vesico-aortic reflux. This is the shape. The plain film is showing us the dystrophism in the lower lumbar sacral vertebrae, and this is a flame shape like urinary bladder, so we lost the normal rounded shape. This is abnormal shape urinary bladder, trabeculation, multiple diverticuli, typical of a neurogenic bladder. Small size neurogenic bladder is the typical, associated with diverticuli, and this is another example, and here you find the surface is more smoother than the one in the previous image. What is the role of a VCUG neurogenic bladder? We are going to tell the urologist and the physician what is the capacity of that bladder, the shape of that bladder, and if there is diverticuli, and we are going to tell them about the function, that this is a true neurogenic bladder, and how the child is emptying his bladder, and if he's on intermittent catheterization, we take image after we empty the bladder through the same catheter. We don't remove the catheter. We keep the catheter in the end of the VCUG. We empty the bladder. Then we take image, and we say that this catheterization was efficient to empty the bladder completely or not. And this is an example of a child who can empty his bladder completely. Neurogenic bladder, look to the plain film, through a neurogenic bladder, but he's using his abdominal muscle to empty it completely. He doesn't need intermittent catheterization. This entity, we need to understand it well. Those are neurogenic bladder by behavior, but there is no reason we can see to make them neurogenic bladder. There is no dystrophism, there is no trauma, there is no tumor, but they are behaved like a neurogenic bladder. That's why we call them non-neurogenic and neurogenic bladder. There are three types. Either it's easier for us to call them hyperreflexia, hyporeflexia, and dyssynergia. Hyperreflexia, commoner in females. You put a small amount of contrast, and the child will empty the bladder immediately. There is a very significant, strong reflux in those bladder, and this is hyperreflexia. The internal, external sphincter are normal. There is no residual urine, but the bladder is a small bladder with hyperreflex. Lazy bladder is the reverse, hyporeflexia. You put about 1,000 ml, and you see that the bladder is distending the whole abdomen, and he is not feeling, or she is not feeling anything, no desire to pass urine. And in the end, we have to push them to pass urine. They push a little bit of urine outside, then they stop micturition. There will be a large residual urine. There is nothing wrong with the internal or external sphincter, but the muscles are very floppy muscles, hyporeflexia. The most common of those three types is the third one, Hinman syndrome, dyssynergia. The detrusor muscles contract, internal sphincter open, but the external sphincter is closed. And that's why there is like outlet obstruction. The bladder is large, thickened, trabeculated wall, and can have divertically, and you will find the child are able to pass a small amount of urine, then stop. Small amount of urine and stop, and this is Hinman syndrome, non-neurogenic neurogenic bladder. This is the picture we are going to see with the lazy bladder. It is not rounded. It is elongated, lobulated, very floppy. There is no contraction, and the child will use abdominal muscle or pushing himself to pass a small amount, large residual urine. Hyperreflexia. Another example of hyperreflexia. And this is example of Hinman syndrome or non-neurogenic neurogenic bladder, where you find in this male, the bladder looks like a neurogenic bladder, trabeculated, elongated, and the child tries to micturate. Look to the posterior urethra. It is dilated, but the external sphincter is closed. They pass very little, they stop. Very little, and they stop. Behave like a neurogenic bladder, but it is not a neurogenic bladder. Another example of a male with Hinman syndrome, and you can see the dilated posterior urethra, intermittent micturition, and the bladder is not as bad in trabeculation like the other one, associated with reflux, and there is reflux into the seminal vesicle. You can see it in the last image on the right. This is picture of a female with the Hinman syndrome, and if you look to the urethra, it looks like a carrot shape because the external sphincter is closed, internal sphincter open. She tried to micturate. It is difficult, intermittent micturition, and they go very frequently to the bathroom. What about the urethra? If the opening of the urethra, external urethral opening, is above the normal place, we call it epispadias. If the whole bladder anterior wall is open to the abdominal wall, like what we have seen in the ectopia vesica, this is one type of epispadias. If we have the urogenital and the anus is opening to one opening, this is a cloacal exstrophy. And in all these conditions, you will find the symphysis pubis is widened. If you look to the external urethral meatus, you find that the child is micturating and the urine is going up. This is mild type of epispadias. We have seen this ectopia vesica and the abnormal shape of the bladder after repair. And this is a hypospadias, which is the reverse of the epispadias, which we have talked about. Prostatic utricle. Prostatic utricle is remnant of the Mullerian system of the female. And that's why I call it the male uterus. I thought I am the only one who's calling it like this, but I found in the internet some people are calling it also the same thing. Seen in normal population, it could be very small, but when it is large with recurrent infection or calculus, this is indication for surgical resection, and could be large enough, and we can see it by ultrasound, VCG, MRI, and CT. If we look to this image and look to the posterior urethra, you see from the posterior urethra that there is, there is something in the back there which is a tiny prostatic utricle. This is an example of a bigger one, prostatic utricle, which is there. And this is a bigger example of prostatic utricle. And this is a giant prostatic utricle sitting behind the urinary bladder. In ultrasound, if you look to the images on the left side, you can see the urinary bladder is the one anterior and the prostatic utricle in the back. And that image on the right side showed the bladder has emptied and some of the urine has gone into this prostatic utricle and some has gone out. Urethral duplication always comes in the sagittal plane, and if the accessory one is opening directly to the bladder, there will be incontinence. If it is opening after the internal sphincter, there will be no incontinence. And this is the picture which is showing double urethra or duplication of the urethra. Urogenital sinus, when we have the urethra and the vagina, is of having a common passage into a single urethral meatus, and this is in female could be associated with congenital adrenal hyperplasia. And this is an example of urogenital sinus, and you can see that this is the vagina, and this is the uterus above the vagina, and they are joining together into elongated urethra in female. And this is urogenital sinus. Bladder outlet obstruction could be due to different causes: posterior urethral valve, anterior urethral valve, polyp, atresia, giant prostatic utricle, similar to what we have said before, or could be tumor rhabdomyosarcoma. This is an example of posterior urethral valve, where you find that the posterior urethra is dilated up to the external sphincter. Then it is intermittent micturition within anterior urethra. If you look to that collapsed urinary bladder, you are seeing that it is a thickened trabeculated wall. This is an example of posterior urethral valve and intermittent micturition. Anterior urethral valve. Anterior urethral valve is nothing but a diverticulum in the anterior urethra. If you look to the first image there is no diverticulum could be seen. After we remove the catheter, the diverticulum starts to fill with contrast. So during micturition, the diverticulum, which we call the anterior urethral valve, is going to be filled with the contrast, and when it is getting bigger, it is going to obstruct the penile urethra and causing the obstruction. So anterior urethral valve is nothing but a diverticulum which is causing obstruction during micturition due to the filling with these. So those children, this is another example. In the beginning of micturition, there is nothing. Then this diverticulum is filled with the contrast, causing penile urethral obstruction. And those children are smart. They learn that this balloon, which is coming in the inferior surface of the penis, is the cause for the obstruction. So they squeeze it and they start micturition again until it is filled again and causing the obstruction again. So it is a cyclic phenomena, and they learn this thing. This is another example of anterior urethral valve, which is associated with urethral stricture. Megaurethra. Megaurethra is due to the defects which can happen in the corpus spongiosum or corpora cavernosa. If it is only the corpus spongiosum, it will have a scaphoid picture. If it is all the corpus spongiosum and both corpora cavernosa are missing, you will have a megaurethra of a fusiform appearance. And this is a megaurethra which you can see it has a scaphoid picture, and this has a fusiform picture megaurethra. What is wrong technique we may do? Neurogenic bladder, don't use Foley's catheter. We said that we almost always use feeding tube, but we may use Foley's catheter and only in special cases, like ectopia vesica, if there is a normal bladder, but there is continuous leakage due to patulous internal sphincter. But in a neurogenic bladder, you want to know the capacity. If you use the balloon, you are not going to know the capacity well, and you may increase the pressure to an acceptable limit. And this is a wrong technique. Don't radiate yourself. Here, the one who's doing it is using his finger in the field of radiation. And here, if you look to those images with ectopia vesica, we have used the Foley's catheter in order to see the reflux. If you cannot reach the bladder because of tortuous urethra, don't do VCUG by injecting the contrast. This is dangerous. You can see in the last images some of the vessels. So there was intravasation of the contrast, and you may cause septicemia by this way. So in order to do low radiation, good VCUG, do good collimation, don't do continuous fluoroscopy, and you can store the images rather than expose the child to the radiation, and you can use the grid and low pulse digital fluoroscopy like 3 per second. This is when you use a 3 per second digital fluoroscopy and you store the image. The images are not very beautiful, but you can have some information. And for a vesicular reflux, you know the types of it. Type 1 if it is only the up to the ureter. 2 if it is reaching the collecting system but no dilatation. 3 if there is dilatation. 4 if there is more dilatation with tortuous ureter. And 5 if there is clubbing of the calyces and there is tortuous ureter. And these are the types. 1, this is 2, and this is 3 with dilated collecting system, and this is duplex collecting system. And here we have type 4 vesicular reflux, type 5 when it is tortuous ureters with the dilated collecting system, and this is reflux into transplant kidney, and this is type 4 into transplant, and type 3 into native kidney, and this is neurogenic bladder with reflux. Sometimes when we do VCUG and we do ultrasound after that, we see that it may match or not match our finding. Here the ultrasound is matching this VCUG. We know that type 2 vesicular reflux will have no dilatation in the collecting system, but here also the same thing. There is dilatation in the collecting system in VCUG ultrasound, and here is type 5, which is also matching. So type 5 VCUG is matching the ultrasound. But if you look to this one, there is grade 4 vesicular reflux, and the ultrasound showed no dilatation. What does it mean? This means good news. The elasticity of this collecting system is still preserved. Save this child. Do something now. When it is dilated, this collecting system is not going to be reversible. It will remain dilated. And in the duplex collecting system, I don't think I have enough time, so you know the upper moiety is opening lower down, and the ultrasound of single collecting system will look like this, and the ultrasound of duplex collecting system will have double moiety of collecting systems. Thank you.
Thanks a lot, Dr. Khalid, for the outstanding talks. And if you have any questions from audience.
No questions?
No question. So we'll close the first session. Please, Dr. Khalid. تفضل يا هاني.